Speaking of family members, good timing, who have been so supportive as well. It's great to have you all here. We appreciate everybody coming out. I know we're in for a spectacular series this year. Before I introduce today's speaker, I just want to give a couple plugs for the next two upcoming talks in the series. So the October presentation on October 17th will be by Dr. Alicio Perez-Stable, who is the director of the National Institute of Minority Health and Health Disparities Programs at the National Institutes of Health. Be telling us about the science of minority health and health disparities. And then the November program on November 7th will be Vicky Arroyo. She's the executive director of the Georgetown Climate Center and professor from practice, assistant dean of centers and institutes at Georgetown University Law Center. And so these are obviously topics that I think they're important and near and dear to all of us, and look forward to seeing most of you, if not all of you, at the upcoming talks as well. So without further ado, it really is a great pleasure to introduce today's speaker, Dr. Julie Pulerwitz from the Population Council. Dr. Pulerwitz works for an organization whose tagline I love, and I just need to read it. It says, "The Population Council conducts research and delivers solutions to improve lives around the world. Big ideas supported by evidence. A model for global change." I mean, can we adopt that, Cyril, for Virginia Tech? I love that. Anyway, I think it speaks to not only Dr. Pulerwitz's work, but the work of the council that I know many of you are familiar with. Dr. Pulerwitz did her undergraduate work, received her bachelor's degree at the University of Pennsylvania in international relations, and then went on and did her graduate work to obtain master's and doctoral degrees at Harvard from the School of Public Health. She served as an associate of the Harvard Center for Population and Developmental Studies earlier in her career, and then has been involved at the Horizons Path program, the Program for Appropriate Technologies in Health, involved with behavioral health change studies, been involved with running many major programs, one of which was the USAID funded program, about, $100 million or so, for global HIV AIDS operations research for successful prevention, care, and treatment strategies with respect to HIV. She's managed a number of programs with respect to implementation of behavioral health change throughout the world, across Africa, across Asia, across Latin America, and many of the countries in those areas, in those continents. She became director of the HIV/AIDS, TB, and gender violence global program at PATH in Washington for gender rights, leading to community evaluation of community empowerment programs in Senegal, a very important program, and then also ran the ARISE program for cost effectiveness for HIV prevention for at-risk populations. About 6 years ago, she assumed the role of Director of Social and Operational Research for HIV/AIDS at the Population Council, and about 3 years ago became Director of the overall HIV/AIDS program there. So she leads that program. She spearheads implementation research, and for those of you who don't know what that is, you'll learn, but it's about actually taking things we've learned in various venues and studying how they actually work in the real world, implementing things that ought to work. And as part of that, she's spearheaded programs there for generating evidence about what works and what doesn't work in different cultural contexts to influence all the way up to policies, and I mean large-scale policies as well. She's a very accomplished behavioral scientist in her own right, a leader in the field of implementation science, in particular studying behavioral change communication, gender, male engagement, and stigma. And we had, I think, a rich conversation earlier about stigmatization crossing many areas, whether it be in sexual behavior, transmitted diseases, or addiction and substance abuse, or mental health issues, and indeed, stigma or stigmatization is still a great challenge, even though we like to think we live in relatively enlightened times and maybe have gotten beyond those things. Those are enormous challenges and have direct impact every day on the lives of individuals and their health. Among her many contributions, she's known for methodological and conceptual work for developing scales to measure power in sexual relationships and gender norms. And this has actually has been the basis for a large body of work where attitudes and behaviors can actually be rigorously and quantitatively compared across different contexts, cultures, and populations. This has led to shaping HIV and gender-based violence prevention programs literally all over the world, including the continents that I mentioned. Dr. Pulerwitz has been recognized through a number of awards and recognition. Earlier in her career, she received a fellowship from the Ford Foundation for Social Science Research on Sexuality Research. She received the Gold Congressional Award of the United States Congress and the Outstanding Young Professional Award of the American Public Health Association from their Population, Family Planning, and Reproductive Health Division. So there's a lot more I could say, but it's not my talk, it's her talk. So without further ado, please join me in welcoming Dr. Pulerwitz.
Thank you. Well, I don't think anyone's been kind enough to read through most of my CV for a long time. So thank you very much, Dr. Friedlander, and thank you kindly to everyone for inviting me today. I'm delighted to be here and to both share with all of you my experiences, and my colleagues' experiences working with these issues globally, and particularly working with different communities around the world through the lens of implementation science to try to curb the global HIV epidemic. One of the points I would like to highlight during the discussion is around certain key topics that really impede the success of HIV and AIDS programming, and they include stigma and discrimination, they include access to health care, they include gender-based dynamics, and I think you'll see the parallels between what is happening all over the world with issues that happen close to home as well. So very relevant for our domestic setting as well, and thinking about what some of those lessons might be. I thought I'd start with one slide about the latest around the global HIV epidemic. About 38 million people are currently living with HIV around the world. There has been, over the last few years, a UNAIDS call to achieve what's called the 90-90-90 goals as a way of trying to control the epidemic globally. So these 90-90-90 goals are to have 90% of people who are living with HIV know their status, 90% of those people be on treatment, and 90% of those people be virally suppressed. So in this case, healthy themselves and not transmitting to someone else. And so those are kind of our global goals. And this gives you a sense of where we are today. About 79% of people globally know their status, which is quite an advance. We've made lots of advances in that area. There's been a big push around HIV testing around the globe. 62% have accessed antiviral therapy, ART. So what that means is about 40% of people who should have access and should be on medication are not, although it's a glass half empty, half full kind of look at this, in that millions and millions of people are now accessing life-saving drugs that had not been just a few years ago. And about 53% are virally suppressed, meaning where we want to go to keep them healthy and not continue to transmit the virus and continue the epidemic. So as you can see, there's still quite a bit to go. And what about prevention? Prevention has, the number of people who are acquiring HIV each year has dropped quite a bit around the world. But we're still at almost 2 million people a year acquiring HIV. So this is still a huge epidemic ongoing. And about 1 million people died from HIV-related illnesses in the past year, even though the majority are on medications. The way that we have addressed HIV, as well as a number of other topics within the Population Council, is to partner closely with communities, to work closely with communities to generate evidence about what works to strengthen programs and improve policy. And these vulnerable communities, often called key populations in the context of HIV, are disproportionately affected by HIV. So about half of the people who acquired HIV last year were a member of what's called a key population or their partner. And they're particularly affected because of being stigmatized populations, being criminalized, or unequal gender dynamics. So what I mean by that is, for example, if you're a young woman in South Africa trying to negotiate condom use with your partner, you often don't have a lot of control over whether you're going to be using a condom or not. And when you look at certain particularly vulnerable populations, I'm highlighting a few here, the first being men who have sex with men. So it's a term that's used in the HIV field. It's become MSM is the term. Men who have sex with men. And this evolved because gay men are an important group here in the US and globally as well around HIV transmission. But there are a number of men who also have sex with other men who don't identify as gay. And we wanted to make sure that we covered the entire population of the issue is the behavior and how we're transmitting and not who you are. So that's why we're calling the group MSM, men who have sex with men. And as you can see, they're 22 times as likely to be living with HIV as people who are not MSM. And in fact, homosexual acts, it's not homosexuality, but homosexual acts are illegal in more than a third of the countries worldwide. And you can imagine if it's illegal behavior, you're not as likely to access services. You're not as likely to share your behaviors that might put you at risk. So this is a very important factor, the criminalization, the stigma that leads to MSM being at risk of HIV. The same we could say about sex workers, both men and women sex workers, but most often female sex workers. They're 20 times as likely, 21 times as likely to be living with HIV as those who are not sex workers. The sex work community, global, worldwide, they're very mobile. They move from place to place and very hard to reach with services. And so these different groups are particularly vulnerable and also particularly hard to reach. We'd say the same thing about PWIDs, or people who inject drugs, who are 22 times as likely to be living with HIV. And then a recent estimate is about 15% of all people who inject drugs are living with HIV. Again, criminalized, again, marginalized. And then the final example I wanted to share with you is a group that has been more recently considered a key population. People have been overlooking adolescent girls and young women, particularly in sub-Saharan Africa. And it was in the about 2014 that it became clear over and over that young women are acquiring HIV at extremely high rates in Eastern and Southern Africa. About 7,000 young women a week are acquiring HIV in sub-Saharan Africa, much more so than their male counterparts. And because of this, now there's been an increasing attention in trying to empower and support young women to reduce their HIV risk. So I'm highlighting these vulnerabilities, and our conclusion is that an effective response to the HIV epidemic will be to take this directly into account and to meet the needs of these pretty distinct populations. So people who inject drugs are not the same as sex workers or not the same as adolescent girls living in a rural village in Kenya, and you have to bring the right information, the right services, the right outreach to meet their needs. At the Population Council, I work with a number of evidence generators, researchers, who work on the biomedical side and on the socio-behavioral side. But the underlying goal of our research is to particularly work with vulnerable populations, but to generate evidence that can improve programs and strengthen policy. So we try to be very practical in our work. Our work can span all different types of methodologies. We do randomized controlled trials. We do clinical trials. We also have conversations and focus group discussions with representatives and stakeholders in different local communities. So we do a range of methodologies, but the goal is really to be practical input into programs and policies to strengthen it either globally, nationally, or locally. I direct the HIV program, as was mentioned, so that's sort of my area of expertise, but the topics I'm talking about are really very cross-cutting. I thought I'd highlight just a couple of pieces of the Population Council's kind of catalytic work over time. So a statistic that I'm always impressed by and I'd like to share is that 20% of all women who contracept in the world are using a product that was developed by the Population Council. So that's 200 and I don't know how many million women, 285 million, I think, at last count. So there's a huge biomedical kind of wing to what we do. So whether it be developing just a recently FDA-approved year vaginal insert called Anavera, the copper T IUD, diaphragms, inserts over time. The goal of the Population Council has been around choice, and individual choice and family choice, and having a very patient and client centered perspective. Another, in parallel, kind of from the socio-behavioral science side, we were some of the early pioneers of the, and I can't say we, it's not me, it's we as a group, but Judith Bruce, Anrum Jain, focusing on quality of care as a framework. So at a time where we were talking about reproductive health being all about coverage and year protection and getting that person onto a contraceptive, what they brought forward is we really need to think about the needs of the individual woman, the individual family, the partnerships, the communities, so that they have lots of options and choice. And quality of care means directly understanding their needs and offering options. So a lot of this work, I mentioned we use lots of methodologies, but a lot of this work can be considered under the umbrella of implementation science. And so implementation science is really trying to ask practical questions, generate evidence with how-to questions to take the findings from the labs or the findings from the clinical trials where we say, okay, we know this medication now works, but what will it mean to actually bring it to Kenya? Or what would it mean to actually bring it to Kenya in an urban setting versus a rural setting? Or what would it mean to actually bring it to Kenya to reach the women who come to ANC clinics versus MSM who are not coming to any services? How would you possibly find them? So those kind of questions, how to reach the right people, how to offer the choice, how to get them engaged with service delivery, how to have impacts on their lives. It also bridges the perspectives of what are really multiple stakeholders. And the kind of multiple stakeholders I'm talking about, when you think about program implementers or you think about service providers, they have certain priorities. It's to get the services as quickly as possible and as with high quality as possible to their clients, right? And if you come in trying to develop evidence or collect surveys or to say, can you now take an hour of your time to ask these questions, they're not so crazy about that idea often. They have to focus on something else. Researchers, on the other hand, are really interested in understanding what's working, what's not working, how can we improve what's happening. But to do that, we have to do it in a pretty systematic way. You have to do it in a way where you ask everybody who comes through the clinic for a certain period of time or whatever that may be. And so there are different perspectives. And then there are the policymakers. Policymakers at a national level, but also more on a community level, where they have other constituents. And the questions that they come up with, what they think is important, may not necessarily be the same as the researcher, or same as the program implementer. So it's important to bridge these different constituents so that you have findings that are questions that are relevant for a particular setting, findings that are applicable for a particular setting, and something that will really improve the lives of the people around them. To do this, we promote this process of integrating research findings into practice through something we call often research utilization or data for decision making. And so it's a frame, a systematic frame that we use. These are some of the guidelines that we've created around this. So that takes you step by step from who are the right people to talk to in the room or in the community or in the nation about these topics first, identify those key stakeholders who can make decisions later, who could be champions of this work. You engage people all along the process of the research. You then take the information that you've gathered and share it with communities. You share it with the people who are going to be using it to help interpret it together. What is this actually telling us? We have a finding that we don't understand. How can we use this appropriately? What does it mean? And then you share these findings with different audiences. So we publish a lot of peer-reviewed publications in scientific journals, a lot of books, a lot of working papers, but we also develop briefs that are appropriate for policymakers who don't want to read more than 2 pages. We also develop sort of guidelines and how-tos for programmatic people who said, just give me that one piece of paper I can put above my desk to remind myself what types of questions I have to make sure to ask, and standard operating procedures. And so we also then encourage having a data use plan. So what are you going to do with this information that you've now collected, or this conclusion you've now drawn? How can this really make a difference? And then go ahead and try to implement that systematically. So that's the frame. And what I'm going to be now sharing with you are various case studies, various examples of how we do this in different places, but I'm also going to be sharing with you the actual results of the research, which is probably the most interesting part, but also show you how it feeds into this systematic process. And ultimately, what research impacts will look like, it will guide program refinement. It will also influence those policymakers, because it's not just evidence generated that influences policymakers. In fact, some people say that policymakers are not basing their decisions on evidence at all. It's based on making those connections and making sure you're answering the questions that they care about, that they feel that they can share, politically. There's always a political issue with these type of topics that we're talking about. HIV, stigma, MSM, criminalization. You also shape the research in general. So you're going to shape the field, you're going to shape based on knowledge generation, and you engage a lot of key partners, whether they be on the community level and activists involved in HIV, or working at the global UN/AIDS level. So here we have that first kind of phase I was talking about, the design phase, where you're identifying key stakeholders, you're figuring out what are the key research questions, you're developing your research ideas, you are putting this all down on paper, you're getting this approved, and getting through IRBs, by the way, about these very complex topics can also be challenging. Because if it's something that's criminalized and you're looking at that behavior, what does that mean when there's an IRB review? So you really need to work in consult with different case stakeholders. And the first example I want to share with you is around PrEP introduction. Building on the point that I mentioned earlier, that adolescent girls and young women are particularly at risk of HIV in sub-Saharan Africa, Eastern and Southern Africa. And whatever has been done to date, it's not working. So there's been lots of money poured into protecting young women from HIV, but it obviously hasn't been working. They're unable to negotiate condom use. They experience a lot of sexual violence, so they don't have a lot of control over when and if they're going to have sex. And you need options. And so PrEP, what's called pre-exposure prophylaxis, is kind of a version of antiretroviral medication, but you can take it to prevent acquisition of HIV. And this is one of the new best biomedical technologies that are being used over the last, I think the really positive results came out in 2012. It was in 2015 that WHO guidance changed from, well, we're only going to make PrEP available to discordant couples, for example, to say that we need to make PrEP available to anyone who's really high risk of HIV. And that will include adolescent girls and young women. And that took us in a whole new direction. So you're going to make PrEP available to girls and young women. That's important, but that means that they're sexually active. How do you navigate this? Well, many of them are married in this context, but in other cases they are not. So how do you navigate all of those issues in different countries? So countries need contextually relevant information. In Tanzania, they came to the Population Council and said, we are not ready to do this. We don't want to approve it yet, but we want to know more about how we could do this. How would you roll this out? What do our different constituents think in the community? What do girls think? Or we particularly said, we want to know what girls think. So what we did is early engagement of stakeholders. So there was that example of the design phase I was saying. This is the first study in Tanzania to assess the feasibility and acceptability of oral PrEP for young women. So that took place probably 2015, let's say. We brought together key stakeholders from the national government, from the National AIDS Control Program, for example, made sure that they were PIs with us on the research itself, that they got to inform the questions. This was a very important part of it, that the national government was part of this study, and that they then wanted to champion it as it went on. And they convened this meeting originally. It wasn't us, it was them. This is something that they really think is important. Let's talk about what the kind of questions are. As part of this process, we developed a conceptual framework. So this is Population Council's work and a guide for how you would do this. But the main point that I want to say here is we're building on what's often called a socio-ecological model, where you see that individuals who are in the middle are affected by lots of other things around them. What they think and what they want to do is important, but they also are affected by their partner. How do you negotiate this with their partner? They're also affected, in this case, by their parents. Many of them are living at home. They're young women. They're adolescents. They're also affected by their communities and their community norms and the stakeholders in the community saying it's okay, it's not okay. And they're affected by policy. So that's kind of on the demand side. And on the supply side, providers are a really important part of this. Are they going to offer it to girls and young women when they're given it and told that they should? That's a question. And the various different health system components. So there's the supply side and the demand side. So now I'll share with you a couple of slides about what the results were. The first one is that people are really worried about provider stigma. So the providers themselves said, look, we often are not very supportive to young women when they come to the clinic to ask for contraception, for example, or to ask for services, saying that they're at risk of HIV. The quote on the right, for example, some of us are very critical and judgmental. We just judge someone. Ooh, you came again. Last time you had gonorrhea. Did you do it again? So they're very judgmental. Not all providers, but many in this context. And they were worried about it. And in fact, we looked at quantitatively so that those who had negative attitudes about adolescent girls and young women, and in this case, that's a range from 15 to 24-year-olds, being sexually active were less likely to be willing to offer PrEP. Also, they were really worried that if they offered PrEP, there may be what's called behavioral disinhibition, or people are now going to be more risky and more promiscuous because they are now feeling safe and protected from HIV. We also talked to partners of girls. And so when I say girls, again, it's 15 to 24, so some of them are husbands, some of them are longtime partners. And what they said is they're a really important process in this decision-making here. They knew that it was important for HIV prevention, for their female partner, also for themselves. It would also be very important if they want to have children, so you want to be protected from HIV, so then you can then go ahead to have children. But they would be supportive only if they knew about it and they were kind of included in the process. First is to get me involved, to involve me in what she wishes to do, which is to use these medications. So they said, and young women were worried too, if they didn't talk to their partners about it openly, that it would seed mistrust. And so a lot of themes, this theme comes up very often through the work that I do. How do you provide autonomy and support to an individual client and at the same time being aware that they're negotiating with somebody else all the time? And they don't want to hide it often because they're worried about what would happen if someone, if their partner finds out. So you have to walk that line of how to engage men appropriately. The parents, too, what they told us is we know our girls are at risk. We've got a huge HIV epidemic here in Tanzania, and they know our girls are at risk. They want to support their young women, but they're worried about the stigma that they will experience because they're saying it's okay, because it's not a norm in their community. So they're worried about it. However, they're willing to, even if she will not go to the hospital, I will go to get her pills so that I can wake her up every day to take it by mouth. So this male parent was very supportive of his daughter doing that. But they're still concerned about the issues that I was talking about. And then lastly, what about the girls themselves? What did they say? They said that they want not to be stigmatized. They're worried about it too. And they want strategies to support effective use. So if we look at how to foster adherence toward the bottom, they want to know more about the side effects about PrEP, about what they should be expecting. They want to have peer support groups so that they can, in person or virtual, and I'm sure many of these things look familiar to you for the people who work in this kind of, on these topics. This works in Kenya the same way it works here. They want reminders versus calls or texts. They want support in the community to try to change those norms, to make sure that everyone knows PrEP is a good option for young women. But they're worried. I shared on the right. When the peers of my age see a person taking PrEP, they'll think the person has AIDS, or they're very unfaithful, hanging out with many partners. They will speak many things, and I will be considered a bad person in the community. I'll be considered misbehaving. And so there's a direct contradiction here of how do you, so here we have this product called PrEP that we know works and would give young women options to prevent acquiring HIV. But there are all these contextual social concerns that you have to address to make it possible to roll it out. I'm now turning it to a second example, more on the biotechnology, biomedical side. So in light of this, there's a whole field going on out there called around multi-purpose technologies, MPTs, where you have a response to multiple needs. So MPTs is an umbrella term. Population Council works with MPTs. But in essence, it's trying to meet multiple needs simultaneously. So in this case, you might have one pill that could address HIV and HSV, or a vaginal insert, or whatever it may be. So STIs and HIV are the most common way people are talking about it. And they're all under development right now in different pipelines, and people are very excited about it. One that we're very excited about is called a CMPT, which is in essence a combined contraceptive and HIV prevention technology in PrEP. Well, you've just been talking about PrEP. And as I started to mention, women both experience substantial HIV risk, but also unmet need for family planning. Another factor that makes it interesting when you think about combining these two is that I talked about this earlier with one of your colleagues, the idea of what's most salient, what's most top of mind to people at that time versus something that might happen in the future. And young women in general are more concerned about getting pregnant than they are concerned about getting HIV, even if they're at risk for both. And so you want to meet that need. And if you combine the two, you would have the benefits of both. And of course, the benefits from a product perspective of having one product versus two products. An oral CMPT, an actual pill, is the fastest route to a product. About 25% of women, of contracepted women worldwide use an oral contraceptive. Were we to go in that direction, and there are pros and cons, but some of the pros include it's a really low in cost investment. It will take not very much time to make it available as opposed to a 20-year process. It could reduce the stigma associated with PrEP that I've been talking about. And it could build on the relatively high continuation rates for oral contraceptives, as opposed to many people are dropping off of PrEP who are using it. This is discontinuation of PrEP is a real challenge that we're experiencing in the world. So about a third of people in 3 months, there's side effects. They don't really see what the positive of it is because you're preventing something as opposed to something making you feel better. It's actually making you feel worse. You have some side effects, which go away, but so many people drop off. So combining the two is considered having real potential. So again, engaging the community, we went to talk to end users, potential end users. We did, in this case, an internet survey with more than 700 women, 50 countries, and asked these various questions. How do you want this combined? Do you want this combined? What should it look like? Which are different clusters of women that prefer one option versus another? And we see the takeaway message is that most women want choices. This is not a surprise to us, but we see similar evidence. But here we are, want different options. And also when you take a life course perspective, women need different options at different points in their lives. You wouldn't necessarily want the same thing when you're 20 as when you're 40. So no one size fits all. 83% prefer a combination, and they want choice. So the council has gone on to develop ideas for a particular piece of biomedical research that can move this forward. And the goal is to test the response to an oral contraceptive regimen that also provides PrEP for women at risk of HIV. So it's combining the two. It was just approved by NIH yesterday, so I got permission to share this information. I wrote an email saying, can I actually tell people? And they said, yes, it's official now. So just approved yesterday. So what this will look like is an oral pill where you combine the two for days 1 to 21, and it's just PrEP for the last week. And we're going to do it through a process called co-packaging. So for those of you who know something about product development, there's a big difference between co-packaging and co-formulation. So we're not currently putting together the meds right now. What we're doing is essentially taking the two pills and covering them with something, and then you take one big pill. And we'll see how well that works. There's going to be a lot we're going to learn about it. And then the next step will be to co-formulate. I'm now turning to the implementation phase. So what I wanted to highlight before is the importance of engaging stakeholders early, getting input early on to influence how things are going to go. What I forgot to mention is that about the PrEP study in Tanzania, and I took out the slide, so that's why I forgot to mention it. But so after we collected this information, shared these results back from the government, we were put on an advisory group with the government, and they formally approved the rollout of PrEP, including for adolescent girls and young women, in 2018. So this was a process that engaged the government along the way, and we ended up with a national policy change. So it's very exciting because many countries have not yet approved PrEP. So they were an innovator in many ways. So coming to the implementation phase. So what I mean by this is the time where you're collecting the data, how you're analyzing data, how do you engage communities well then to improve your programs and policies. And the first example I want to share with you is around something called the People Living with HIV Stigma Index. This is a tool that was developed in 2008. Stigma has been an issue around HIV from the very beginning of the epidemic. Whenever you go to a meeting or a program, the first slide is usually talking about stigma, or the last slide is saying we weren't effective because of stigma. And so stigma has been a huge issue the entire life of the HIV epidemic for the last 30 and more years. And in 2008, a tool was developed, largely led by the communities of people living with HIV, to document this stigma, to use it for advocacy purposes, to use it to show how much stigma there is in different contexts, to talk about what does it look like, how can we change it. And examples of the kind of stigma that they're looking at, for example, ranges from gossip about me to social inclusion. I'm not invited to my neighbor's house anymore, to physical harassment on the street, to being fired from a job, and to being murdered. I mean, there's a big range of what happens because of stigma and living with HIV. And so this was developed in 2008, and then hundreds of thousands of people have now taken this tool, this survey in essence. It's administered by people living with HIV, so it's a great opportunity to create rapport. It's almost an intervention in and of itself. And we work to help technically support this, to help strengthen it for research purposes. So you ask the questions in the right way. So you can analyze it in the right way and combine it so that you sample from the right selection of people, not just the people who are walking in the door that day, so that you know that it's representative of the community, for example. And it was updated a couple of years ago to reflect the current state of the HIV epidemic and the response, meaning that when it was developed originally, there was almost no medication available at all in many of these contexts. And so now there's a lot more information about antiretrovirals and how stigma might take place in different healthcare settings. To do this update, and I just want to share with you what this takes often. So this is not something you normally write in your protocol. You're doing your research, you do your survey, done, done, done. This took over a year of desk review, key informant conversations with people from the community who've been administering it in the past. We had an in-person stakeholder meeting to ask people, well, what's missing here? What else do we need to know? And some very important feedback came out of it. We synthesized these recommendations. We have an updated questionnaire. We then pre-tested this questionnaire at the International AIDS Conference in 2016, got that feedback. We updated it again, formally pilot tested it, and then shared the results. So it was a multi-step process. The main new features of this tool look at some of the issues I talked about earlier. One key point about intersecting stigmas. So this is kind of the state of the art around understanding stigma is that there's not just one kind of stigma. People represent a lot of different things, and there's lots of different stigmas that people experience. And how do you take that into account? So there's stigma related to being HIV positive, and it may be that people are worried about transmission of HIV to them, and so they don't want to touch them or they don't want to be near them. That could maybe be taken care of more by information and education. But what about the stigmas associated with being a member of a stigmatized group? like being gay or being a sex worker. Those are value judgments that are really, really difficult to change. And they come together and make those populations even more vulnerable to HIV. So how do you tackle that? So that's one question. All those healthcare issues I mentioned, that now that we have a much more robust HIV care service option, often in those contexts there's not a lot of stigma. Those people are trained to work with people living with HIV. But what about when you need to get your eyes checked or you have something else going on and they know you're positive, but they're not trained to work with HIV positive people. So those are other issues. And then we spend a lot more time about mental health issues, because internalized stigma is a very important factor for people living with HIV too. That those elements of they blame themselves as well, and it affects their behaviors. We also, and this is on the other front, on the other side, we also developed what we call the resilience scale. So something that came from the community was to say, it's not all about stigma. It's not all awful. We also have been resilient to experiencing living with HIV, and we want to capture that and to show what that looks like, and to try to foster that in other people. So we developed a scale to look at resilience. So we fielded this work in Senegal, Cameroon, and Uganda. And here's just a few slides about what we saw. Really high levels of abuse experienced by men who have sex with men. So you'll see like 80% of men from Cameroon said that they were verbally harassed. 67% were blackmailed because of living with HIV, and 54% physically harassed. So just in Cameroon, you see that those are the blue bars are really quite high. When you turn and to internalize stigma, how they feel about themselves because they're living with HIV, whether they blame themselves, whether they feel ashamed, it's also very substantial, and even more so for men who identify as MSM than those who do not. And so we really need to tackle that directly. There's stigma from the outside, but there's also stigma from the inside. And transgender women, who we know very little about in many of these countries, they're normally kind of lumped together with MSM often, have very different experience, or have somewhat different experiences than MSM in general. So you'll see that there's really high rates of blackmailing, harassment, etc. And then my last slide with findings is to say that we also saw a great deal of resilience in the communities that we spoke to. So it's a 10-item scale, and it looks at your ability to cope with different things. Has been positively not affected or negatively affected by my HIV status. And it's a substantial proportion report that they've been resilient in the face of HIV. And so we're now trying to explore what leads to resilience and how we might promote that elsewhere. Turning now to my second example in the implementation phase section, we are now back at looking at HIV risk among adolescent girls and young women. So now this is this big effort by the US government, PEPFAR, USAID, to try to reduce risk among young women. And while there have been substantial declines amongst girls and young women, uncontrolled epidemics. So an example is up to 14 times higher rates amongst young women than amongst their male peers in many of these countries. And this is compounded by something that we talk about a lot called the youth bulge. So there's a lot of young people who are surviving childhood, which is terrific in these contexts. So now many more of them are growing into adulthood and are going to become sexually active and develop relationships, et cetera. And so it's predicted to go from 100 million, like 2010, I think, to 200 million in 2020. So it's going to be a huge, even if we do nothing else and don't, it's going to get worse, the epidemic. So young women's vulnerability is multifaceted. I touched on some of these issues. Some of it's biological, that their mucosal lining is less developed and it's more likely to pass on HIV. Some of it's behavioral. They can't negotiate condom use. Some of it's societal. There are norms saying that men should be controlling behaviors of women in general. It's also structural in their access to healthcare. So there's all different issues that young women face. Hence, they created a program to try to address all of these issues simultaneously. And it's called the DREAMS Partnership. And the acronym is Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Women. And it's a public-private partnership. I think many of you are familiar with that in the room, with PEPFAR. And we were funded by the Bill and Melinda Gates Foundation to conduct the implementation science work around these 10 to 15 countries, to figure out what are we learning, what's working, what's not working, are you reaching the right girls, et cetera. The DREAMS package tries to address the various different vulnerabilities that I'm talking about. So on the one hand, you're trying to empower young women and reduce their risk by making sure they stay in school, by offering cash transfers, by making PrEP available to them, by education. You're also trying to reduce the risk of their male partners, to understand more about that so they don't transmit to the young women. You're also trying to mobilize communities for change, and then finally to strengthen families. So it's a really multifaceted program. Our first question to try to understand how these community-based programs are working was, did we identify and try to recruit the most at-risk girls? Because that's your first question. In environments where you have really high HIV incidence, and that's where the program went, which is good. It's a place where there's a lot of HIV incidence, and you're trying to layer all these programs on top of each other and see what kind of impact you get, hopefully positive. How do you distinguish who's most at risk, who's most vulnerable, when many, many people are vulnerable in your community? And so we did a cross-sectional sample to look at the community and also looked at who are the DREAMS girls. Did this in Kenya, Malawi, and in Zambia. And we found that, in fact, there were very high concentrations of HIV risk, as we had assumed and hypothesized. We also saw, and here was a new finding for the Kenyan authorities when we were doing this work, the rates of sexual and physical violence were enormously high for these young women. So it's like 25% of young women in Kenya experienced violence from their partners in the last 12 months. Another 20% sexual coercion from partners, and also non-intimate partners. So it wasn't just the partner, it was the uncle or the person in the community. So there's just a lot of sexual and physical violence that these girls experience. And those who experience violence were twice as likely to report an STI symptom and anxiety and depression in both Kenya and in Zambia. So what we then fed back to the government and to the programmers is to say, you have this twin epidemic, which we knew theoretically, but it was only when you put those numbers in front of them, they said, oh, we're not focusing on that enough in our program. So they started changing the program and to try to make more of a push and an effort toward addressing violence. And so that's an example of taking results, turning it back really quickly. So this was more from our kind of early tracking. It's not what was the impact of the program. It was early on, what are we learning that you can feed into programs right away. And then we ask, well, who are you reaching with your DREAMS programming? Are you reaching the right girls? So it turns out they're reaching many at-risk girls, and this program's been going on for the last 2-3 years. So those with high STIs, those with multiple partnerships, those who experience sexual violence. But there are also other subgroups that they weren't reaching so well that we knew needed to be reached, like girls, young women who are who are married, and women who are not in school. So there are certain subgroups that we weren't reaching as well. So they really tried to focus on that. Those who, they reached more women who use condoms than they did the women who didn't use condoms, for example. So they needed to, let's say, redouble their efforts to reach certain subpopulations. We now know, because this is kind of hot off the presses, that there have been some really positive changes over time amongst adolescent girls and young women enrolled in this big DREAMS program. The US government ultimately invested, I think, $800 million into this work. Or maybe it was across the partnership. So it's a huge program, which is now in 15 countries, and we're seeing some very promising reductions in risk for young women and reductions in diagnoses of HIV. And you're seeing a range from more knowledge to more HIV tests to less sexual violence, for example. So that's very promising. I'm now moving on to my last phase, and I only have one example here, and what we call the knowledge translation phase. So you have all this information, and how are you informing programs and policy? Something very important is to find champions and work with champions who care about this, and hopefully they're key decision makers, and to develop those materials for very different audiences. And our example here is in Tanzania, and it's focused on female sex workers and how to improve their access to treatment. So these were amongst young female sex workers who were recently diagnosed with HIV, but they're also out in the community somewhere, they're mobile. How do you reach them? How do you continue to engage them in services? Because now you really want them to be on antiretrovirals continuously. And doing this is very difficult. So something that is being talked about and tried to be implemented in different pilots a lot across the Africa, but also many different global contexts, is to bring the services to them. So bring the treatment to them. So you actually, mobile clinics, you have people come out of the facilities. Instead, everyone was very used to, you have to go to that clinic or you're not going to get services. So now trying to actually bring it out to the community, including antiretrovirals, and have not necessarily only physicians track this. You can have not lay people either, but people who are nurses, for example. So we were going to pilot this. This was not policy in Tanzania. It was against policy, and Tanzania in general is pretty conservative when it comes to policy. Very worried about it, but they said they were going to be willing to pilot it and test it out. So the intervention is enormous, and it was implemented by our partner at Johns Hopkins. It was an intervention called SAUT. And between August 2015 and April 2019, they tested over 2.6 million people for HIV and diagnosed more than 125,000 people. And they were particularly looking for key populations and vulnerable populations and their partners. We found that this community-based model significantly improved ART retention. So we didn't see this at midline. You'll see that it was pretty good at midline, which is like 6 months later. About 95% of the people who went through the standard care were also retained. 100% of the people in the intervention. But then when you got to a year out, it dropped down to 77% compared to 99%. So this then we fed back into the Tanzanian government and into SAUT, and they used it, if you look at that second box, to talk to MOH, the local government. They refined their standard operating procedures, the training packages. They used the findings to just improve programming. And then it just strengthens the ART service delivery approaches in general. And then lastly, just a couple of months ago, the Tanzanian government has now changed their policy to allow facility-led but community initiation and tracking of ART for key and vulnerable populations. So this was a major success for SAUT and for us. My last few slides, I think I only have about 2 more, are now turning to the HIV epidemic in the US, just to kind of bring us back here to the US, to remind us about what it looks like here. And here, about 1.1 million people are living with HIV. They estimate that about 15% don't know it, are undiagnosed. And about 40,000 people are diagnosed with HIV. It says in 2017, but pretty much every year since 2013. About 40,000 people have been diagnosed with HIV, meaning that even though the scale is very different than what we're talking about globally, it's not getting better. It's not going down. The incidence rates are not going down. Still 40,000 people every year. It may be slightly different people. It may be in different geographic areas, but we're not yet successfully curbing the epidemic. And only 51% of people living with HIV have achieved viral suppression, which partially explains why it keeps getting transmitted, because they're not virally suppressed. Further, while PrEP has been taken up quite a bit in the US, I think about 450,000 people use PrEP around the globe. It's not that many people, actually, but at least half of them are in the US. It's been very popular here. But still a very small proportion who could benefit from it. So this led to this plan for ending the HIV epidemic in America, which you may have heard about. It was announced, I think, last year in the State of the Union address. And it's a new effort to implement 4 strategies to diagnose, treat, protect, and respond. So diagnose those who are living with HIV, treat them, prevent it being transmitted, and then respond quickly to different outbreaks. And it's going to focus on particularly highest burden counties, and it has a real focus on rural HIV burden. So there's a lot of rural locations where they're now epicenters of HIV. and it also includes Washington D.C. So we've been doing more work in the U.S. now, thinking about how to bring these lessons to the United States. And this is my last content slide with just a couple of concluding thoughts to kind of bring this back together. Clearly, we still have substantial challenges to address the global HIV epidemic and our domestic epidemic. But there are some similar issues that put people at risk all over the world, whether they relate to stigma or gender or health access. And that many of these lessons that we've been learning in our international settings, we can apply here, particularly around engaging communities most effectively. And so I think that that's something that we at the Population Council would love to do more. And I'm just finishing a project in Pittsburgh, for example, with the University of Pittsburgh, which was funded by the CDC, where we're trying to bring some of our, what do I want to say, gender equity promotion interventions, where we're working with young men to try to reduce sexual violence through the YMCAs in Pittsburgh. And we're using that, we're adapting that from some work that I didn't talk about that much here, but lots of work that I've been involved with globally around how to shift these gender norms and gender dynamics between young men and women. So happy to talk about that more as appropriate. And then I would be remiss if I did not really highlight, as you can see, the font's so small you can't even see the names of all of these people. There are many, many people that I and my colleagues in the Population Council partner with in all of these different countries and studies to do this work. And that partnering is a key component of what makes implementation science successful. So, and here are some of their logos. We couldn't possibly fit them on the same page. And I would end with thanking you very much for inviting me. It's delightful to see you.
Thank you very much. Really fantastic. A lot of exciting things. Open the floor for questions or comments. And I'll be glad to go first, if I might. So
Sure.
You've clearly put in place here an infrastructure and a level of understanding that's dealing at the moment with this challenge that's been 3 or 4 decades in the making. And we don't know yet, climate change, et cetera, what the next disease that will cross species and emerge in human population. It just seems to me this is creating an infrastructure that could be part of, for lack of a better term, for our country and for the world, part of the defense infrastructure or readiness. And so my question is, to what degree are governments, our own and or others, embracing the procedures and processes you put in place and rolling it into the infrastructure and funding on an ongoing basis for the next HIV?
Yeah, thanks for asking that. I think I would say that in many of the countries that I work, it was through the incredible the resource allocation around HIV that we've been able to strengthen health systems in general. And it's not probably exactly the same here in the States. We can talk about the States in just a moment. But for example, I went to a clinic in Vietnam where you have a beautiful, white, shining clinic, and then right next door you have a TB clinic, and it was very dilapidated. So I think that with the resources that we've garnered through this emergency and other response globally to this epidemic, it's set up all these wonderful systems in many, many different countries that help strengthen public health in general. I would also say that as a topic, HIV, unlike almost any syndrome or disease I can think of, has raised so many other issues that we're now confronting that will be part of these other types of epidemics. So things around poverty, things around gender-based violence, all of those topics are outside of HIV per se, but have been raised because of talking about sexuality. All of those issues have now been raised that we're now addressing in that context. In the US, I think that the history of having strong advocacy and activism really changed the way that, coming back to the communities intersect with researchers and intersect with governments and how you respond to a disease. Like, we haven't seen that with TB, we haven't seen that with reproductive health, we haven't seen that with a lot of other examples, but it's a great model to think about going forward.
Yeah, no, I mean, we've learned so much, it just seems it would be terrible to lose the momentum for the next thing instead of talking about all this. So, other questions? Yes?
Hi, so my name is Hassan, I'm the second year PhD here. Kind of jumping off of this question question as well. Throughout your work, whether it's specific to HIV or any of these tangential areas, have you seen any barriers that have been produced as a result of public policy? And if you have seen any, how did you guys work together to kind of confront that?
Well, probably the biggest challenge we have are some of the criminalization laws with the populations that we serve in many of the countries. And so we've spent a lot of time trying to walk that fine balance of making services available to people who need it and generating evidence that can help strengthen programs and policy, while at the same time not doing something that's going to further stigmatize them or put them in or put us in a context where we can't function anymore, where they shut us down. So, for example, we were just mentioning it at the reception. We have a big program in Nigeria which works with at-risk men, particularly MSM, and homosexual acts are illegal in Nigeria. And we have a very active, excellent program where we have service providers who are well-trained and sensitive, and a whole network of peers who send people our way, and we generate evidence about how best to reduce stigma and do these trainings, et cetera. And on our community advisory board, and here it's also important to have the community with you, we have like one of the police chiefs locally, as well as a number of other types of groups who are very supportive and champions, as long as it doesn't really get into the media or it doesn't get way to the national government finding out, because then it becomes very difficult. So we try to walk that fine line while at the same time, you kind of advocate over time.
Yes.
What is the outlook to fund the PrEP, since it's over $1,000 a month?
I'm sorry?
The outlook to fund the cost of the PrEP.
Cost of PrEP. In most of the environments that I work, it's not. There's no cost. I mean, for example, in Tanzania, when they're making it available, there's no cost. And much of this work, PEPFAR and others, fund the PrEP itself. For the DREAMS package, I think it was Vive Healthcare and a couple other pharmaceuticals who were donating the PrEP. So it's a little unclear what's going to happen now, but certainly the history globally of how we evolved from unbelievably expensive medications, antiretrovirals, of $15,000, $20,000 a year, where no one could afford them and no one could have access to them, to how that was all navigated on a global level to go down to $300 or $400 a year, generics, et cetera. So that is a good history and example of how we might also address this for PrEP.
Yep.
Just comment on that, actually, the U.S. Preventive Services Task Force just recommended offering PrEP with an A recommendation back in June. And the implication of that is that insurance companies will be required to cover the cost of a recommended preventive service at that A level. The problem is we haven't yet seen what the regulations are coming out of that. But I think that's one of the hopes that we'll actually be covered.
Thank you for sharing that. That's great news.
If I can ask one more question, the
Sure.
combined the birth control and the PrEP. So is there an effect of bulletproof now from anything and a rise in other STDs, for example, or does that not happen?
Do you mean cognitively or you mean reality?
Reality.
Okay.
Cognitively is interesting.
Yeah, I mean, there's a question around behavioral disinhibition, right, as to whether, okay, now I'm bulletproof. But no, it doesn't address other STIs. But the council is developing a multi-purpose technology to address, what is it, it's HIV, HSV, and HPV, I think, currently. So there are various different products coming. They're still a little ways away, like years.
Yes, question in the back.
Hi, I'm Linda. I'm a sex educator in this area, and I was really intrigued by actually something that was stated in your introduction around some of the skills that you've developed around gender balance and gender norms. And I was wondering if you could just say a little bit more about that or put in the direction of being full conversations.
Sure. So another area of my work is I did my dissertation. Let's start with that. I did my dissertation on gender-based power dynamics and HIV risk for women. So that was I won't say how many years ago that is. I was just noticing in the elevator that I am fully gray now, and I have to own this. But moving on, so that was quite a while ago. But that is when I started on this work. And then early on, what was being talked about then, what came out of sort of ICPD and discussions about how to engage men and how to engage communities, were power dynamics. And people were, this is power. This is a fundamental thing in society. How can you possibly change that? So my goal was to try to say, you can quantitatively measure some of these really complicated, difficult topics, whether they be gender norms, whether they be stigma, whether they be male engagement, whether they be power in sexual relationships. And then once you measure them, and I try to come up with it's a mix of an art and a science, these scales, but so a series of items that you can administer easily, answer the question yes or no, basically. You combine them all together, and then I can show that this is associated, the power dynamics are associated with whether they use condoms, with whether there was violence, with all sorts of outcomes. And then I started on a series of studies around, well, can we develop interventions or programs to try to affect this gender norms or power dynamics. And in fact, there have been a number that have developed over time that I've worked with some of the implementing partners and not others. So one that is being used widely is called Stepping Stones. There was a randomized controlled trial in South Africa, but it's now being used widely, and it's basically a community-based intervention. And another one came up earlier was SASA. And then there are several other ones that I'm happy to talk to you about, where it's on the community level to try to change norms, to try to change violence, try to change power dynamics. And if you were to change those, would you see different outcomes? Would you see less violence? Would you see less HIV risk? And so that's been that whole area of work, and how easy or difficult is it to change from one cultural environment to another. Can you do this kind of program in Kenya and in India, or can you also measure it similarly, gender norms? So I started out in doing work in Brazil, and then I went to India, and then I went to Ethiopia, and so it's now been tested in a variety of different places, and that's why it's been robust in how people now track these factors and help design programs. So I'm not sure if that exactly answers your question, but happy to talk more about it.
All right. Please join me in thanking Dr. Pulerwitz.